Well, I'm going to hand things over to Isabella Chu to walk through our first presentation.
Good morning, everyone, if you're on the West Coast, or afternoon if you're on the East Coast, or somewhere in between. So today I'm going to talk about a grant that we had proposed to the NIH, and then it was kind of split apart into several other projects after sort of review of that. And basically it's looking using real world data to better understand COVID, the epidemiology of COVID, its trajectory, treatments, vaccination, and another issue that's arisen during the last 2 years, which is a large spike in all-cause mortality. The next slide, please. Oh, it's like a shadow. Interesting. So this is, oh, there we go. So this is our center. So we've, early on in the origin of our center, we made a huge investment in kind of R&D and tech to host high value, high risk data. And this means that a core team of a fairly small number of people is able to administer those data sets and keep them secure. For individual projects, we typically hire a number of analysts, but this is our core team, and our faculty director is David Rakoff, who's a social epidemiologist. And then we have a number of data managers. Next slide, please. Our approach to population health is really looking at the impacts of real world data. There are many other kinds of data that you can use to study health and interventions, but our center is really chosen to focus on real world data, and that's for a couple of reasons. Next slide, please. The first is, so there are three types of data that centers like ours would typically use. The first is randomized controlled trials, and these are fantastic for things like drugs, as you all know, because they deal with a lot of the things that you would find very hard to control for if you can't measure it. Traditional cohort studies, and we also have relationships with a number of those. But again, going back to the reason we've really chosen to focus on real world data, and particularly data sets like all payer claims or the Colorado all payer claims, is because they deal with a lot of the biases that are inherent in the other two kinds of data. The kinds of people who sign up for studies, and particularly studies that go on for years, tend to be very different than the kinds of people who don't. And so, drugs almost always perform better in studies than they do in the wild, all kinds of things like that. It's very hard to reach certain populations. And so one of the things we were so excited about, and we even have other claims data sets, but one of the things we were so excited about with the Colorado all-payer claims data set is that it really incorporates all sort of socioeconomic strata and is much more representative of the population than, say, a claims data set you purchased from one holder. So that was really our reason for partnering with CIVHC on this project. Next slide, please. So when we think about what makes data useful, and I know I keep coming back to this, it has to be several things. It has to be large and representative of the population from which it was derived, and the Colorado all-payer claims certainly meets that criteria. Longitudinal, so particularly in population health, exposures can often precede diseases by years, even decades. And so the ability to follow people over time is incredibly important. And this data set also provided the ability to do that because people tend to stay in the same state, at least for a few years, and linkable. And there are a lot of ways to do linkage which preserve privacy, confidentiality, and security. And there are a lot of really innovative techniques, hashing, encrypted keys, that kind of thing. And we incorporate a number of different strategies to make sure that these linkages, while adding new research insights, don't increase risk, re-identification risk, or privacy or security risk. Next slide, please. So the aims of the covered project are pretty simple. We want to look at the incidence, prevalence, course, and outcomes of COVID-19 and the variants. The efficacy and equity of the distribution of the COVID vaccines. And again, working with a state is particularly helpful for that because the vaccine registration data is typically held at the state level. And so, you know, kind of matching it with a state APCD is probably the best way to answer that question, as it's taking a while for that data to get into EHRs and claims. And finally, long haul COVID. This has been a real problem. You know, I'm sure you're all aware that there are very high incidents of long COVID. And again, the longitudinality of these data really allow us to follow these people to see how they're doing, what the long-term trajectory is. And then finally, there's a real concern. So over and above the COVID deaths, there's been this 20% spike in all-cause mortality. And, you know, there have been a number of papers about this at this point, but we really want to understand what's driving those extra deaths to inform what interventions can sort of help reduce all-cause mortality. And, you know, the next group is going to talk about mental health, things like that may actually be explaining this, or they could be uncounted COVID deaths. We're not sure, or a number of things. Next slide, please. So the data set that we're using in conjunction with the CIVHC data is called the American Family Cohort. And this is an EMR data set in about 6.5, close to 7 million patients now from 3,000 practices. And so by combining these data in a secure, encrypted way with outside data sets, we're able to get a complete picture of the patient. And to give you an example of the kind of biases that can be introduced when you don't do this, we have a claims data set, and in that claims data set, African Americans do better than white patients. And so without a complete picture, you can often get the wrong answer. And so we're really excited to be able to look side by side at these data sets and get insights into COVID. Next slide, please. So this is, you know, extremely preliminary work we've done with this data set in partnership with the CDC. We're the data set that we have, the AFC, is disproportionately rural, which are individuals that are typically or often not included in other sorts of EHR claims data sets, although that's getting better. And so we use the ILI and COVID-like illness to sort of map COVID rates early in the pandemic before there were tests, especially in these rural areas. And even now there can be test shortages. So we're trying to use sort of a symptom-based profile to track COVID incidents in rural areas. Next study, please, or next slide, please. So that's it. That's our planned work. We do have a grant with CDC to study this, and we're excited to work with both Colorado and the American Family Cohort to get insight into the latest COVID waves, how the vaccines are playing out, and the increase in all-cause mortality. Thank you.